Good morning, everyone. Welcome to Donate PPE Medical Physics Webinar 2. Now we have Ian Paddick, Distinguished Medical Physicist from UK. I am pleased to welcome him on behalf of the OncoRise Foundation to this webinar. Indeed, we know him and he requires no introduction as the father of Gradient Index, Paddick Index, as well as the author of a number of peer-reviewed scientific publications. He has been the past president of International Society of Stereotactic Radiosurgery, International Stereotactic Radiosurgery Society, and the current president of BRSS, and many more. And today he will be talking about sublethal repair effects in SRS. So we have more than 200 participants from different continents: Asia, Europe, Africa, and even from US, North America. So this campaign is to involve awareness and to generate support in terms of PPE donations. So please feel to use the question tab and type your questions, as the microphone will be muted throughout this webinar. You can also type your message if you are willing to contribute as a volunteer, as we know many of those who are attending the webinar are experts from different parts of the world, or if you want to donate PPE. Once again, I thank Ian for volunteering this lecture, irrespective of his busy schedule. Dear friends, please join me today in welcoming Ian onto the stage, giving full attention. Ian.
Thank you very much, Sajeev. I really appreciate your this initiative. I think it's a fantastic way of helping the medical community and also helping provide PPE. So my talk today is radiobiological BED modeling of SRS, the inconvenient truth. I'd like to thank John Hopewell as a co-author in this work. So what are we actually talking about here when we talk about repair? We're talking about the repair of sublethal damage which takes place on the DNA strand. For every gray of radiation that every cell in the body absorbs, we get approximately 30 double strand breaks. We get approximately 1,000 single strand breaks, and these are the ones that are more readily repaired. But also we get intrastrand crosslinks, base changes, base losses, DNA protein crosslinks, and sugar damage. We get many different types of damage, and these are repaired often, we think, at different rates. So this is how we normally view DNA repair. We think of it in radiotherapy as repair that takes 24 hours to take place, even though we know deep down that it's an exponential process. And in this chart here, we have the surviving fraction of cells, and you can see that if you deliver a single dose of 1000 centigrade, that's 10 gray, that's the equivalent of 4 daily fractions of 4.5 gray. But the repair process is more complex than this. So how do we investigate what we call DNA repair kinetics? Well, we can use cell survival assays. There've been many cell survival assays over the years. These can be difficult, though, for high doses because very few cells survive. And remember, what we want here is data for radiosurgery. For radiotherapy, you might give a 2 gray fraction, and to perform cell survival assays is very, very easy. But when you're treating with radiosurgery, you might have a cell survival rate of just 0.001%. And then cell survival assays become more difficult. We can also use animal models, but we know that those are very expensive. And we can also look at DNA strand breaks. So this is a chart from a very old paper where on the x-axis we have radiation dose, on the y-axis we have surviving fraction. So this is a classic cell survival curve. And you can see that the amount of cell kill varies dramatically depending on the dose rate. Now, the dose rates here go anything between 0.0003 gray a minute up to just over 1 gray a minute. Now, people will say, well, this radiobiology is all very interesting, but it doesn't affect us, and conventional radiobiology doesn't apply at high doses. And one of the reasons for that is that it's been very, very difficult to perform cell survival assays at high doses. But actually, if we look at this chart again and look at these dose rates, they are extremely relevant to the SRS community. Obviously, it depends on what device you're using, but treatments can take a long time, from maybe 10 minutes up to sometimes a couple of hours. And if you look at the three lower survival curves here, you can see that they're the equivalent of 18 gray in 17 minutes. Well, that's something that we experience in a clinical situation. 18 gray in 60 minutes, and then 18 gray in 112 minutes. And yet you've got about a 100-fold difference in cell survival for exactly the same dose. All you're doing is delivering that dose over a different treatment time. So does this really affect us? Yes, it does. Any treatment that lasts more than approximately 10 minutes, or in fact less now, we found out that less, even in 10 minutes, if you're delivering 20 gray, that can reduce the biological effective dose by around 10% from if you're giving the dose acutely. From the first isocenter, beam, node, or arc to the last. So we've seen cell survival curves. What about animal models? There's this paper by Luke Popp that was published in 2000. You can see on the lower left there's an X-ray of a rat, and there they were using brachytherapy sources to irradiate the rat spinal cord and to look at the DNA repair kinetics involved. And you can see here the chart, which is the proportion of responders. And you can see that the sigmoid curves there vary dramatically from one to the next, simply because of the dose rate applied. And so what we call the ED50, that's a proportion of, or at least the dose required for 50% of the rats to develop myelopathy. If you've got a relatively high dose rate, it's around 23 gray. And if you've got a lower dose rate, it can go up to about 30 gray. Now, from this animal model, we were able to plot the ED50 for radiation myelopathy versus the overall treatment time. And until this point in time, a mono-exponential repair function was used. And you can see the mono-exponential repair function on this slide is in green. And as a result, you can see that at the overall treatment time of between 0.1 and 1 hours, you get a deviation from the actual observed data. And so you can see, to get a perfect fit with the observed data, you need to use a bi-exponential repair function with a fast and slow rate of repair. Now, that can be quite difficult to do because if you use a bi-exponential repair function, you can't calculate in Excel. You need to use more advanced mathematical programs to do that. Now, some people have said, well, you can't use studies involving rats. And so here is a pig spinal cord study, fairly similar experiment. This was some work that was performed by John Hopewell and Bill Miller. They thought that it was not worthy of publication, but with the resistance to accepting the concept of sublethal repair in the SRS community, it was eventually published in Physica Medica. And you can see here two groups of pigs. One receives 25 gray at 0.9 gray a minute, and 100% of those animals developed radiation myelopathy. And then you have another group of pigs that received 25 gray in just 0.2 gray a minute, and you can see that none of those pigs developed radiation myelopathy. So a significant difference in the ED50 from 21 gray up to 27 gray, just depending on the dose rate. And these dose rates are what we observe in practice. I think one of the problems with the Gamma knife community is when we think of dose rate, we think of the reference dose rate. And when we get a new Gamma knife with new sources, we have a reference dose rate of about 3.5 gray a minute. That might decay down to about 1.5 gray a minute, and then we replace the sources. But actually, the overall treatment time, or the prescription dose divided by the treatment time, that's really the dose rate that we should be considering. It's not the reference dose rate of the machine. Now, you can also use repair kinetics, or you can count the number of DNA strand breaks in cells, and you can observe the repair kinetics that take place. And this is work that was performed by a German group in the 1980s. And in fact, using this technique, they were able to resolve 3 separate repair components, one that had an extremely short half-life. We're talking about less than a minute here. But the work done on animal models, we have fast and slow repair rate estimates for spinal cord using Luke Pop's work, Kian Ang's work in the 1980s with spinal cord, with identical fast repair times, ever so slightly different slow repair times. And then Miller and Hopewell published some work on acute skin reaction. And even though skins are very different tissue, you can see that the fast and slow repair times are extremely similar. So really, it seems as though they are common for all mammalian cells. It doesn't matter what they've differentiated into. DNA repair is a fundamental enzymatic reaction that takes place in every mammalian cell. So we have the radiobiology community has come up with the biological effective dose, and the biological effective dose, or BED, is physical dose modulated by treatment time and or gaps in the treatment during which the DNA repair can take place. And a model using 2 repair processes is most appropriate for normal tissue and CNS. So we have a short repair half time of about 0.19 hours, which is just 12 minutes, and then a long half repair time of about 2.3 hours. And these are equal in weight. So how certain are we of a bi-exponential model? Well, we have animal models. They've verified that a bi-exponential repair. We have cell survival assays, and we have DNA strand breaks. So all of these agree with each other. So the evidence is overwhelming. So BED is given a subscript to describe what alpha-beta ratio it relates to. So a lot of this work uses a BED of 2.47. This was the BED that Miller et al. Concluded was appropriate for CNS tissue. So is single session radiosurgery a fractionated treatment, or is it just a prolonged treatment? Well, for the Gamma knife, we have isocenters or shots. For a CyberKnife, we have multiple beams that take place over a period of tens of minutes. For a LINAC, we can have multiple arcs that can take place over tens of minutes. And all of these methods divide the treatment up into mini fractions. So let's consider a single cell. How does it view the treatment? Some people say that with Gamma Knife, we spot weld each part of the tumor one bit at a time. But I think if I show you the charts here, I will hopefully be able to convince you that that's not the case. So these are the dose profiles with treatment time. This is a treatment that took just over 2 hours to deliver on an old Gamma Knife Model B. So there was around a 6-minute gap in between each of these individual isocenters. But I think you can see these are 3 different voxels on the same physical isodose surface. You can see that the dose rate profiles are very different, and particularly in the bottom left chart, you can see there's no single isocenter that's giving the vast majority of the dose. In fact, with the 2 top charts, even though you do have one isocenter that's dominant, both of those isocenters deliver less dose, considerably less dose than all the other isocenters put together. So because we have this sort of mini fractionated treatment, even though we call it just a single treatment session, we have a very complex calculation which needs to take place. So this is the complex BED calculation, bi-exponential calculation that's been proposed by Miller. And that's the inconvenient truth. We've got the same dose, the same physical dose, but we can have a different BED in the same patient on the same physical prescription isodose line. And unfortunately, every point on the dose calculation grid requires a bi-exponential calculation to correct for dose rate or gaps in the treatment. And that's very difficult to do. How do you get the dose rate and treatment gaps for every single voxel? Well, our research group has a custom version of GammaPlan that allows us to do that. At the moment, we haven't been able to get such a thing for CyberKnife, but it's something that we're very interested in looking at. So we then need to apply the lower calculation here, the one in the middle of the slide, to every single dose calculation point. And that takes a lot of time. So what does this all mean? It means that treatment time affects the BED of a treatment. An isodose line doesn't have a constant BED. It can easily vary by 10% as you trace around that physical isodose line. Excessive bathroom breaks, cone beam CT breaks, or couch kicks can reduce the BED of a treatment easily by 10% or more. And the fractions that are delivered may already have a significant element of short-term repair completed by their conclusion. And so the basic LQ model is invalid for the vast majority of radiosurgery treatments. Now, people say, but SRS cell survival and clinical studies looking at dose rate and BED don't show any effect. Well, let's look at the most recently published cell survival study. This was produced by the group based in Oxford in the UK. And here we irradiated a series of mammalian V79 cells at different doses and at different dose rates. This was deliberately, these cell survival studies were deliberately done for the benefit of the SRS community to be able to demonstrate that there is a dose rate effect. And so we use typically the doses that are used in SRS over the sort of treatment time ranges that are used for SRS. Now, if we look here at, let's say, a clonogenic cell survival of 0.1%, you can see that on the black line, where there's a higher dose rate, there the dose rate is 6 gray a minute, you need about 18 gray to get a 0.1% cell survival. But if you use the blue curve on the right, is just 0.2 gray a minute, and there you need somewhere around 24 gray for the same cell survival curve. Now we can rearrange the data to look at what we call ISO effect curves. So if you look at the right-hand curve here, and we look at, let's say, a surviving fraction of 0.001%, that's the brown curve. If we deliver the dose acutely, so that means certainly less than 5 minutes, you require about 26 gray to get a surviving fraction of 0.001%. If you deliver radiation over a period of 120 minutes, then you require somewhere around 35 gray to get the same effect. So that's a 37% increase in dose for exactly the same ISO effect. People still say, well, cell survival studies have shown no relevance in the processes involved in vivo tumor control or the precipitation of radionecrosis. I disagree with that, and we now have clinical studies that show the importance of BED. So the first, let's just look at a simple model. Let's look at SRS for trigeminal neuralgia. I call this a simple model because with trigeminal neuralgia, for the gamma knife, we use a single isocenter. So we have a single continuous exposure, almost always with a single isocenter. And so the BED equation becomes a lot more simple. Beam blocking is likely to be an important confounding factor because that changes the dose distribution in the nerve, and we get the phenomenon known as the Flickinger effect. So here is a clinical study by John Lee and his group in Philadelphia, where they actually showed that a higher dose rate for gamma knife provided earlier and longer lasting pain relief. In this group, all patients received 80 gray, and there was a dose rate effect observed. The flaws in this study are that the reference dose rate of the machine was used. Fortunately, the treatments tended not to have plugged shots, and that's really important because plugging, of course, doesn't change the reference dose rate of the machine, but it changes the dose rate at the trigeminal nerve, which is what we're interested in. So there was a dose rate effect seen in this, but they didn't use BED. And there's a paper that we published late last year in World Neurosurgery. Again, we were looking at SRS for trigeminal neuralgia, but this time we used BED. So this was the very first SRS clinical study comparing dose versus BED to look at clinical outcome. It was a Marseille cohort of 497 patients. Beam blocking was a confounding factor, as was acute response and transient recurrence. So we had to be very, very careful looking at this data to avoid bias in the study. The group was extremely heterogeneous in terms of the physical doses used, and that's great because that means we get a wide BED, and so we should see an effect, both in dose, if there is a dose effect, or in BED. So the doses range from 75 gray up to 97.9 gray. And the overall treatment times varied from between about 25 minutes all the way up to 130 minutes. So when we looked at BED versus the incidence of freedom from pain at 1 year and 2 years, there was no statistically significant effect between BED and the incidence of freedom from pain. And you can see that for 1 year, the incidence of pain-free is just over 90%. For 2 years, it's just under 90%, but you can see very little effect in terms of BED, and that wasn't statistically significant. When we looked at BED versus dose for numbness, so that's the top left chart there, you can see very little difference indeed. In fact, the lower group tended to have a higher incidence of hypoesthesia. There's no particular pattern between physical dose and the incidence of numbness. But when we looked at the incidence of numbness versus BED on the bottom right chart, you can see a really astounding dose effect relationship. And what we're seeing here is the classic sigmoid curve that we see on dose response curves. So what we're looking at now are 4 curves with different BED values, and they correspond to different incidences of hypoesthesia. So the yellow curve at the bottom correlates with around a 5% incidence of hypoesthesia, the white 10%, the red 20%, and then the highest BED value around 40%. And you can see the 2 dotted lines that we've drawn on the chart. This was prepared by John Hopewell. If we look at 30-minute delivery time, you can see if we keep the treatment delivery time the same, you can see a very clear dose response curve. But of course, that's not what's happening in real life, particularly over the lifetime of sources and whether you use beam blocking. And so if you look at the horizontal white dotted line, there we're prescribing a dose of 85 gray. And you can see that depending on the treatment time you use, you can move from the 20% incidence group down to the 5% incidence group. So what we're seeing here are the classic dose response sigmoid curves that we see in radiation oncology. Typically, these will be for tumor control. The white one would be for tumor control, and then the red curve would be for normal tissue complications. But in this case, for trigeminal neuralgia, it's pain control on the left and hypoesthesia on the right. And you can see that the results that we got are very, very similar to different points on the curve. So if we go to the 90% incidence, the sigmoid curve is very shallow at that point. If we go and look at hypoesthesia now, where we got an incidence between 5% and 40%, we're on a steeper part of the sigmoid curve. And we can exploit that in order to optimize the therapeutic window. So you see here, no significance in difference in pain control, but a significant difference in complications. And so we published a lookup table that allows you to adjust the dose according to the inpatient dose rate. So if we look at the 3 columns on the left, if we want to prescribe a BED of 1820, which corresponds to a 5% incidence in hypoesthesia, we look at the inpatient dose rate, that's column 3, and let's say we have an inpatient dose rate of 1.2 gray a minute. Then we look to the left and we can see that the dose we need to prescribe is 83 gray, which is delivered in 69 minutes. The right 3 columns are for a hypoesthesia rate of 10%, if you feel that you'd rather give a slightly higher BED. So this is the first instance where we've been able to prescribe iso-BED treatments for SRS. It's the very first time in history that that's been possible. There's another interesting paper that was published recently, by the group at Columbia University in New York. This was looking at treatment outcomes and dose rate effects following gamma knife for vestibular schwannomas. And what the group found was that there was a statistically significant difference in the dose rate, or at least the incidence of hearing loss and dose rate. You can see that in this table here. For multivariable regression, tumor size and dose rate were the only two statistically significant parameters, not dose, it was dose rate. Now, myself and some colleagues wrote a letter to neurosurgery commenting on this paper, which was, it was good, and it showed that there was a dose rate effect, but we did show that the problem with just using a dose rate is that's not the same as BED. And remember, they were looking at the reference dose rate in the machine. So here what we've done is we've plotted a series of 255 vestibular schwannoma patients treated with the Model B and with the gamma knife perfection, and we've binned those according to the overall treatment time. So the brown columns are for those with a higher dose rate, and then the blue columns are those with a lower dose rate. And you can see a huge amount of overlap between the two. And this is why using the reference dose rate of the machine doesn't work. You know, we know that on any day we can plan, let's say, a vestibular schwannoma, and if we're lucky and the shape's just right for the isocenters that we place on that target, we can have a really short treatment time, let's say 25 minutes. But if it's a very complex shape, we need a lot of smaller isocenters, and we might have a treatment time of 90 minutes. That's got nothing to do with the dose rate of the machine. It's just got to do with the complexity of the treatment, how many isocenters you use. And to demonstrate that, we have this table that we published in the same letter. If we look at the bottom three rows for the gamma knife perfection, we can see what we've done here is we've looked for treatment plans that were clinically delivered, but we've adjusted the reference dose rates of those clinical treatment plans so that they will deliver a treatment in exactly the same treatment time, even though the reference calibration dose rate of the machine is either 1, 2, or 4 gray a minute. So the 1 gray a minute treatment plan, of course, has a lower number of isocenters, while the 4 gray a minute treatment plan has a lot more isocenters. These are all given in around 50-55 minute treatment time. And you can see that the mean BED of those treatments is almost identical. So that shows you there that it's the overall treatment time that affects the BED. It's not the reference dose rate of the machine. Now, there have been more works since then. There's been 2 publications from the Mayo Clinic. Chris Graffio has published on AVMs, and also it found a BED effect on the insulin-like growth factor index after treatment for pituitary adenoma for acromegaly. So how can we calculate the BED? Well, clearly the equation that you see here is extremely troublesome, but Blidden-Jones and John Hopewell from Oxford have published now in the BJR a number of methods that you can use to estimate the BED. First of all, in that paper, there's something called equation A9. This is still a bi-exponential equation, but you need very little, few parameters to be able to calculate. So you just need the total dose, the total treatment time, and the beam off time as well. So this allows you to estimate the mean BED of your prescription isodose. And this is the method that was used by the Mayo Clinic to publish the papers on pituitary adenoma and AVM. So it's a very usable equation that can be accessed for your data. There's also a table 1 in the paper, and that's an even easier method. This is just a mono-exponential equation, and this allows you to look up your prescription dose. That's a left-sided column, and then you have an equation. It's a mono-exponential fit to the data, and you simply key in your treatment time, and you get the BED as a mean BED. Now, this works very well, but not for particularly short treatment times or particularly long treatment times. So if your treatment time is between 20 minutes and about 100 minutes, then this is a good formula to use. But at extreme times, that's where just using a mono-exponential fitting isn't really good enough. And then you really need to go to the bi-exponential equation A9. But using table 1, I was able to apply that to a spreadsheet of cases that I had for vestibular schwannoma treatments. This chart took 10 minutes to produce. It really was that simple. So this is over 300 patients treated with 13 gray. So I had the prescription dose, I had the overall treatment time. I simply put the table 1 formula into Excel, and this is what I was able to obtain. So here, this is a plot of the BED for all of those treatments delivered. And you can see that even though we gave exactly the same dose of 13 gray, this is a really heterogeneous group. The BED varies by as much as a factor of 2. So the highest BED treatment was actually an old Model B treatment with a single isocenter, just 11.3 minutes of beam on time. The lowest BED treatment was a Model B delivered with 20 isocenters, 131 minutes of treatment time. But of course, you've got gaps in between each of the isocenters. It took 264 minutes to treat that patient. And you can see as soon as we switch from Model B to perfection, you suddenly get an increase in the BED, and you actually get a more homogeneous BED. But you can still see that it varies dramatically. So we have hot treatments that are in excess of 10% above the mean, and cold treatments which are in excess of 20% below the mean. So I hope that this shows you how heterogeneous the treatments are that we're currently delivering, because we're assuming that prescription dose is directly related to clinical effect. And we know that's not the case now. It's BED that is related to clinical effect. So actually, looking at that chart, this is just showing you the mean value for Model B was 59.5. For perfection, it was 64.8. So significantly higher there, almost 10%. The minimum value for the Model B was 31.7, the maximum 72.9. An instantaneous treatment with 13 gray results in a BED of 81.4. So you can see that even the maximum dose there is still significantly lower than 81.4. Now, I showed this to John Hopewell, and he kindly, a couple of days ago, recalculated a couple of points. If you remember, I said that table 1 is only suitable for treatments between about 20 minutes and 100 minutes. And the shortest treatment and the longest treatment there were outside of that range. So actually he used equation A9, and actually the minimum value was 42, the maximum value was slightly higher at 74, but that's still a huge range there. There's also a correction table, which is extremely useful to use. Again, I would advise users to use maybe between 20 and 110 minutes for that, because you can see here, once you get outside of that range, you get a significant difference. So the black line here on the chart is equation A9. That's a true bi-exponential equation, while the straight line there is what we have on this correction table. And you can see that at long treatments, we start to get a deviation from the true values. But we can use this to normalize our treatment. So here's one example. We want to deliver a reference dose of 13 gray, and we're going to, our reference treatment time is going to be 1 hour for all of our treatments, let's say. So how do we adjust a treatment plan that has a physical dose of 13 gray, but this plan is delivered in 110 minutes? Well, we simply look on this table. We find 13 gray. Here we've got 12.5 gray, which is the nearest we've got to 13 gray. That's good enough. We look down at 110 minutes, and we have a correction factor of 1.08 to apply to our treatment. So the physical dose that we apply is 13 times 1.08, which is 14 gray. A second example, we want to deliver a reference dose of 25 gray delivered in 30 minutes. So how do we adjust the physical dose of 25 gray that's delivered in 120 minutes? Well, here we use 2 cells from that table. So the physical dose to be applied to that 25 gray is 1.1 for the 120 minutes that we've currently got, and we divide that by 0.92, which is the treatment time that we want to normalize the treatment to. And that means we need to deliver 29.9 gray in order to get the equivalent of 25 gray in 30 minutes. As I already mentioned, using these techniques, the Mayo Clinic have produced 2 papers, and in fact here you can see on the right the chart showing the difference in biochemical remission between patients that received a BED of greater than 200 and those that received a BED of less than 200. So how certain are we of a bi-exponential model? Well, we have animal models to back this up, cell survival assays to back this up, DNA strand break studies to back this up, and we've now got clinical studies on trigeminal neuralgia, AVM, and pituitary adenoma. So I think the evidence is now overwhelming. So to summarize, cell survival studies have shown that repair takes place during treatment in the SRS dose and treatment time range, leading to lower cell kill for protracted treatments. Animal studies have shown the same effect for myelopathy and other tissue responses. 2 repair processes with half times of approximately 0.19, that's about 12 minutes, and 2.3 hours are dominant. The dose delivered is modified by the overall treatment time, resulting in the biological effective dose. Due to the significant in-treatment repair, the basic LQ model is not appropriate for converting fractionation regimes for gamma knife, cyberknife, and long LINAC treatments. And there's actually a real danger of dramatically overexposing patients if shorter treatments are delivered using dose schemes that were empirically derived from older gamma knife, cyberknife, and LINAC doses. I'd like to acknowledge with many thanks to Bill Miller and Bledin Jones for supporting this work, of course John Hopewell, who's a co-author, and the statisticians in Oxford are thanked for their significant guidance in the evaluation of the Marseille trigeminal neuralgia data. So I'd like to thank you for your attention, and I'd like to hand over to questions.
Thank you, Ian. Thank you so much for the impeccable presentation today. And before we go to the questions from the audience, I have a question, whether any studies available on the metastatic tumors regarding the same?
At the moment, no, unfortunately. I'm sure that's something that will come. I think with the BJR paper, suddenly researchers from all over the world have access to a basic BED estimate. And it was amazing how quickly the Mayo Clinic came up with two papers. I was actually a visiting professor at the Mayo Clinic the week after the BJR paper was published. So in my talk, I was able to say, look, you can now calculate the BED, and there are two fantastic studies that have come out of the Mayo Clinic already on that. Trigeminal neuralgia as well, we've published. We're looking at other clinical groups at the moment. Metastasis hasn't happened yet, but I think that's going to happen. What you need to do when you're looking at performing a study on radiobiological parameters, you need to ideally look at a treatment which is where you have approximately a 50% success rate. And the problem with radiosurgery is that our success rates are just too good. And that causes a problem, because if you're at 50% success rate, you're at the very steep point on the sigmoid curve. And so a small variation in BED can make a big variation to your clinical effect. But if you're at 90%, as I showed with trigeminal neuralgia, then actually you don't see a BED effect at all. So that's a problem. Maybe we're more likely to see a BED effect on large metastases, because they're ones that we have problems with, either in terms of tumor control or certainly at the incidence of radionecrosis, which is, can be easily 20% for large mets. So I think that's where the work needs to be directed.
Many thanks for the excellent presentation. Once again, I have questions. So we have a few questions from the book. Do we have dose rate effect in, there is a question is about brachytherapy. He's asking, do we have dose rate effect in brachytherapy after 12 gray per hour?
Absolutely, there's a dose rate in brachytherapy. What was the overall treatment time there that you mentioned, Sanjeev?
Treatment time, he has not mentioned anything here. In brachytherapy, it is, yeah, he just asked a question. Yeah, I think he's confused. Yeah.
So yes,
so we have
there have been there are definite dose rate effects in brachytherapy, and the UK experienced that when they moved from low dose rate brachytherapy to higher dose rate brachytherapy. And unfortunately, a mono exponential repair was used to convert doses from low dose rate to high dose rate. And I understand that resulted in severe complications for a lot of patients, because the radiobiological modeling wasn't appropriate.
Okay. So the next question is, what is the radiobiological mechanism behind ultra high dose rate radiotherapy? I mean, flash radiotherapy.
Okay, yes, that's a very interesting. So my understanding is that maybe I should go back to, we know that tissue hypoxia is potentially the main reason why we get local failure in radiotherapy, because hypoxic tumor cells, because there's less oxygen, you need oxygen to fix the DNA damage in the nucleus. And with the absence of oxygen, repair can more easily take place. And that's one of the main reasons why we get failure. Now, what flash radiotherapy does, my understanding is that because it's delivered so quickly, all the oxygen in normal cells gets used up. And as a result, you get less damage in normal tissue. And what you're doing is you're leveling the playing field. So the hypoxic tissues get the same amount of damage as normal cells, when we know that hypoxic tissues normally require between 2.5 and 3 times the dose for the same amount of cell kill. So my understanding with flash radiotherapy is we're just leveling the playing field, and that the hypoxic tissues are equally as sensitive as normal tissue.
Okay, thank you. Another question is how we compensate the unexpected treatment gap, like a toilet break, or if we split 6 hours treatment into 2 days.
The first question, if I can do this in 2 separate questions. So the first one, how do we account for a toilet break? That's a very good question. I'm afraid this is a problem with this BED in radiobiology. You know, it's an inconvenient truth, and I think that's the reason why the radiosurgery community hasn't really embraced it. You know, it may only just starting to, because we'd rather not know that there are problems, you know, that if you give your patient a toilet break, it actually makes a difference to the treatment. We'd rather not know that. So what can you do? Well, number one, you can discourage patients from taking toilet breaks. I've been to centers before where the nurse or the radiographer setting up the patient tells the patient, you know, your treatment's 40 minutes long. If you need a toilet break at any point, just put up your hand. We'll be happy to get you out and give you a break. And I don't think that should be happening. I think we should be asking our patients to go to the toilet before they start their treatment, and encouraging them and telling them that the treatment is less effective if you have a break. So please try not to take a break. We've done some work recently with a PhD student at UCLH. In fact, we've just submitted a paper looking at a 10 or 15 minute toilet break, and where in the treatment does it make the greatest difference? And believe it or not, it makes a difference. So if you take a toilet break towards the beginning of the treatment or towards the very end of the treatment, it can make, don't quote me on this, it's somewhere like a 15% decrease in the BED. Sorry, it's about a 15% decrease in the BED at a maximum point, which is at the center of the treatment, right in the middle of the treatment. That's the worst point in which to have a toilet break. But if you have it at the beginning, very beginning, or the very end, then it makes far less of a difference. So it doesn't allow you to adjust the dose, but those are ways that you can reduce there being a decrease in BED. Sajeev, what was your second question on that? The second part?
Or if we split the 6 hours treatment into 2 days, 6 hours treatment.
Right. So I presume this would this be for like a long gamma knife treatment? That's been split
It might be like a fractionated radiosurgery. I think the question might be.
Okay. I mean, we had a case just last week, in fact, where we had a patient with 42 brain metastases treated in 2 separate sessions. And there we had to do some, yesterday I was doing some radiobiological calculations on that. For brain metastases, it's not so much an issue. That if you're going to stop a treatment and you're treating multiple brain metastases, try and stop it at the end of one complete treatment of a MET. You don't want to stop the treatment right in the middle of that metastasis. If you're going to split the treatment up, let's say into 2 days, then it actually makes a very little difference, because remember, with brain metastases and gamma knife, you tend to treat the vast majority of the dose goes to that brain metastasis in a single session. And then the other question about splitting the dose up and hyperfractionating, you've got to be extremely careful when converting a single dose to a hyperfractionated regime. And that's because single dose SRS normally has a significant repair factor included in it. While if you use the basic LQ model, that assumes that the treatment is instantaneous and there's no repair that takes place during the actual treatment. All of the repair takes place between the first treatment and the second treatment. So I think really there it's just a word of caution. At the moment, we don't have a method of being able to convert single treatments into multiple fractions effectively and easily.
Okay. Another interesting question we have is, what is the reference BED to be achieved in the disease of AVM?
That's a fantastic question. I'm hoping that when the full paper from the Mayo Clinic comes out, we might have a better idea. I believe the abstract's been published, but not the full paper yet. And I'm really looking forward to that paper. That'll be Chris Graffio, I think, is the main author there, and that'll be published in Neurosurgery. We really don't know, and this is the problem, that for gamma knife and really for the rest of radiosurgery, you know, we're using empirically derived treatments that have been given maybe with the same physical dose, but over different treatment times. And what we need to do really is go back and look at that reference data and reevaluate it in terms of BED. And then we should find out what the optimal BED is. And really, that's what we did with the trigeminal neuralgia data from Marseille. We reevaluated a cohort of patients in terms of BED instead of physical dose. But that needs to be done for every treatment indication. I think in 5 years' time, I think we will have an optimal BED for the main treatment indications. But at the moment, we don't have that.
Okay. And another interesting question is, does treatment in morning and evening makes any difference?
Is that in the morning or the evening?
Yeah. That's what he said, morning and evening, morning and evening. It is not, or the question is like this. Does the treatment in morning and evening makes a difference?
Well, so I mean, depending what that means, I know there was an interesting paper from, I think, UVA, where they looked at treatments in the morning or the evening, and they actually saw a statistically significant difference in clinical effect, which is beyond me. I don't understand that. In terms of radiobiology, morning and evening, you know, what gaps should you be giving? Certainly, if you're delivering a hyperfractionated treatment, you need to make sure for a full 24-hour gap between the treatment. Because in fact, full repair doesn't even take place in 24 hours. There is a little bit of DNA damage that is not repaired during that time. And one of the problems with radiosurgery is if the treatment takes 3 hours and you're delivering a treatment, let's say at 12 o'clock midday, it doesn't finish until 3 o'clock in the afternoon. And then if the patient comes back the following day, they've only had a 21-hour gap. So we need to be very, very careful of that. And I certainly wouldn't recommend equating you know, a morning and evening treatment as the same as a full 24-hour gap, because there'll be a lot less repair that takes place.
Okay. There are many more questions, but we stop with one more question,
Okay.
which is, is it appropriate to compare the dose distribution in LINAC-based SRS with gamma knife SRS using EUD model?
Well, again, that's got to do with overall treatment time. Overall treatment time is key here. There are some new LINAC treatments that take very little time, and therefore you can't compare the two, because the LINAC is delivering treatment much faster, effectively an acute treatment. So the difference in BED can be 20, 30, 40%, a huge difference. However, there are some other LINACs that take much longer to deliver their treatment, sometimes even longer than a gamma knife. So, you know, the important thing there is, if you're going to use EUD model, you have to, that is only applicable for treatments that are given acutely, so effectively instantaneously. So if you're delivering your treatment in a period of 5 minutes, then that's applicable to use. But otherwise, I'm afraid you have to use a different BED modeling using the bi-exponential repair function, or you can use the BJR paper, which helps you create a BED estimate with less mathematical equations.
Yeah, once again, I thank Ian for supporting the campaign by volunteering the lecture, as well as giving an opportunity for all those who present here to learn from you. I thank all the participants as well for your attention and welcome you to play more active participation in the future webinars. Also by volunteering to share your expertise, because we know many of you are experts in your own areas, in domains. So see you again. Thank you.
Thank you very much, everyone. Goodbye.
Goodbye.